We have no disclosures. Now, and we're going to talk about opioids in kids. So opioids are frequently prescribed for surgery and after injury in children. Increasingly, and this is not just for children, we wonder whether all those opioids that are prescribed are necessary. And we do know that after opioids prescribed in adults and in children, most of those opioids are not used. Why is this a problem? I think I previously had thought that children were more modestly prescribed opioids than adults, that it was not really an issue. I think certainly in my training, for whatever reason, it has always been the case that I've worked with people where we didn't give a lot of opioids to children. But we started looking into whether in fact that was true as part of some other work that we were doing, and we got some pretty impressive results. So we're going to talk a little bit before we get started with the presentations from our anesthesiology colleagues here about just kind of what's going on in the state of Wisconsin with opioid prescriptions. And this data comes from the Wisconsin Health Information Organization, or WIO. It's an all-payer claims database that includes about 75% of the Wisconsin population as a whole, but a much higher percentage for children because what it misses is Medicare. And so we get inpatient and outpatient use. We can align that with procedure and diagnosis codes, and we can get data on prescription fills, meaning a prescription was both written and then taken to a pharmacy and exchanged for medication. So we don't know anything about what people are actually taking from this data, but we do know what percentage of patients are getting fills for their opioids. So the data that I'll show you is from January 1st, 2016 to December 31st, 2017. We can do a lot of manipulation to look at dosing. Because children are such a weight-based dosing conundrum, I'm actually not going to present a lot of data on the weight-based dosing because we just aren't sure. 5 milligrams for a 1-year-old is very different than 5 milligrams for a 17-year-old. We're looking at all patients under 18 who underwent a series of procedures, and only in patients who have continuous insurance coverage for 7 days from the day of the procedure, including prescription drug coverage. And then we excluded patients who had additional procedures. So we're trying to really limit this data to individual procedures performed. In our case, we're looking at basically simple outpatient procedures. Just a caveat, this is not risk or reliability adjusted. These are just absolute numbers. And with that, before we go any further, I want to do something for our audience, if you can. Now, if you're on the phone, this may be hard, but we're going to try it. This is a poll just asking, for these procedures, which would you prescribe opioid pain medications? Ear tubes, circumcisions, closed reduction and pinning of elbow fractures, laparoscopic appendectomies, tonsillectomies and adenoidectomies, and umbilical hernia repairs. If you don't have a chance to do that, that's fine too. Okay. And we got a little bit of data back. So what does that actually look like in our own behavior in the state of Wisconsin? Well, ear tubes are getting about 10% are getting opioid prescriptions. Circumcisions, and this is only in kids under 1, are getting about 3%. Percutaneous elbows, 76%. Lap appies, 60%. Tonsil adenoids, 70%. Umbilical hernia repairs, 56%. That's not what we do here. I mean, we send kids home after laparoscopic appendectomies and umbilical hernias, which I do with no opioid pain medications. Ear tubes was a surprising number for us. Like 10% is not very high, but it's also a lot higher than we expected it to be. Likewise, umbilical hernia repair. And even tonsils and adenoids, which I think there's a little bit more controversy about, like there's 30% of patients aren't getting opioids for them. Another interesting thing is the percent of patients who are refilling a prescription within 30 days. And as you can see there, that number ranges from a low of like 2% for umbilical hernias to a high of 11% for the orthopedic procedures. And that is one marker of chronic opioid use, is needing another prescription within 30 days. And so some definitely concerning signal there. Very similar to adult data looking at similar phenomena in other states. What are kids getting? If you're getting opioids, there's a pretty wide range. Hydrocodone is pretty popular. Obviously, this comes in multiple formulations, often associated with Tylenol. Oxycodone is popular. And what's interesting is codeine is also still kind of in the mix. I was really actually gratified to see that codeine for tonsillectomy and adenoidectomy is lower than the national standard, which is like 15%. But given that it has a black box warning saying that it should never be prescribed for that indication, specifically for airway surgery in children, 3.5% was still a little bit alarmingly high. And it's definitely finding its way around into these other procedures. So that WIO data is part of data that's available through the Surgical Collaborative of Wisconsin, of which is a partner as we have developed this program. That data is something that we actually provide as individualized reports to surgeons on their prescribing behavior around specific procedures. And if you're interested in knowing more about the Surgical Collaborative of Wisconsin, how you can be part of our opioid reduction initiatives, I would be very happy to talk to you about that, get you plugged into that system. With that, I want to turn things over to my colleagues, Doctors Hylton and Casias, and I'm going to invite them up here to talk about their portion of the day here. Get your
advanced slides.
Yeah, just scroll down. Just
Scroll down.
just scroll down. Yeah.
Perfect. All right, so again, I'm Jared Hylton. I'm assistant professor within the Department of Anesthesiology, and specifically a pediatric anesthesiologist. And I also kind of sub-specialize in pediatric acute pain and regional anesthesiology here at American Family Children's Hospital. And we also have...
Yeah, I'm Tim Casias. I also am an assistant professor. I do peds anesthesia with Dr. Hylton, as well as do acute and regional, but I also specialize in peds chronic pain. So I'm the medical director of peds chronic pain here for the American Family Children's Hospital, and we do pain clinic right now. So it's great.
So we're going to kind of give an overview of, post-operative pain management from our perspective as kind of acute and chronic pain specialists. This will be applicable hopefully to the outpatient, inpatient, but also I tried to kind of direct this to be very applicable to the outpatient environment, kids that are getting same-day surgery, outpatient procedures and being sent home, and what to expect with pain control. But first off, why is post-operative pain control and analgesia important? Well, multiple studies throughout the adult and the pediatric literature, when you control a patient's pain more rigorously post-operatively, they have better patient and parental satisfaction. Poorly controlled acute pains associated with the development of chronic pain syndromes, and that's been shown across a number of different types of procedures in varying, from from minor to more severe procedures been shown across the board. The intensity and or duration of postoperative pain, the intensity of it has been correlated with persistent pain after surgery. But things that we are beyond that very concerned about, we're concerned about getting these kids back to their normal daily routine as quickly as possible, eating, drinking, sleeping well, going to school, etc., improve their ability to participate with PT, and also preventing. There's some evidence to show that poor pain control postoperatively is also associated with maladaptive behavioral problems in kids, even regression of milestones, things like once a child potty trained for a couple weeks after procedure, all of a sudden, they're not potty trained anymore. The parents have to throw diapers on for a couple weeks until the acute stresses of surgery, they kind of get past that. As anesthesiologists, there are a number of things that we do to maximize a patient's postoperative pain control, one of which is regional anesthetic techniques. I'm not going to go into this too in depth because there are entire conferences and textbooks on this topic, but we have a variety of different peripheral nerve blocks, single shot, and also catheter techniques that we utilize for post-operative analgesia for our patients. And they can vary from peripheral nerve blocks for upper and lower extremity surgery, truncal nerve blocks for the chest, abdomen, and pelvis, and then also neuraxial blocks as well to help control post-operative pain. And so why do we do this? Why don't we just put a child under a general anesthetic or sedate them and just give them a boatload of opiates post-operatively? Why do we go to all this trouble? The benefits of regional anesthesiology across adult and pediatric literature have been pretty consistent: decreased pain scores, decreased opioid consumption, decrease of side effects of the opioids, such as nausea, vomiting, faster return of bowel function, decreased risk of development of chronic pain syndromes. In the adult literature, at least, reduction in cancer recurrence and actually improvement in cancer patients' overall survival. It's a little bit of a controversial point. There's more studies that are coming out, but at least as of right now, it seems pretty promising. So there's a whole lot of different reasons why integrating these techniques into our patients' post-operative pain control is important. The risks and side effects of these techniques, especially the single shot techniques, the risks are very, very low. The most common things that happen really are catheter-related equipment issues like migration of the catheter, leaking, etc. Things like infection. There was a large sample out of the United Kingdom that showed a rate of infection for epidurals between 0.3% and 0.02%. And that was out of like 10, 15,000 patients. That's a pretty low rate. Bleeding, nerve damage, actual nerve damage and issues with nerve conduction due to the nerve blocks also exceedingly rare, and the vast majority of those issues resolve within 3 months. Local anesthetic systemic toxicity also has a rate of, depending on what study you look at, between 0 and 2 out of 10,000. So pretty rare. And so more kind of practical guidelines for the non-anesthesiologist. How long do these blocks last? If it's a single shot, I typically tell the parents and the patients between 8 and 24 hours. I know that's a big range, but that's dependent upon multiple factors like the type of block, the concentration of local anesthetic we use, etc. And so depending on the block, I'll usually tighten up that time frame. But for everyone else's knowledge, vast majority of these blocks last about a day and wear off within about 24 hours. It's important to note that patients will usually need little to no opioid medications while the block's working. No block's perfect. Sometimes they don't take away 100% of the pain, but they often knock it down anywhere from 75 to 100%. So we overall recommend to utilize these short-acting opioids on a PRA and as-needed basis. We'll continue to schedule other multimodal analgesics. When the block wears off, it wears off actually relatively quickly over the course of about 30 to 90 minutes. Most patients will kind of report that, let's say, their hand will start kind of tingling as the block is wearing off, and then about 30 to 90 minutes later, they'll start experiencing pain in surgical location, and they can start converting over to opioids. There's always been this concern about rebound pain after the block, that there's perception with some people that, well, the pain seems worse after the block wears off relative to the patients that had no blocks at all. And actually the evidence within the adult and pediatric literature, especially the adult literature, does not support that patients actually continue to have decreased opioid consumption even after the block wears off relative to patients that did not have a regional technique at all. Something else, acute compartment syndrome within the orthopedic community is also concerned that a block will mask the symptoms of acute compartment syndrome. And again, that's kind of a controversial point, but there have been numerous case reports and series out there elucidating the detection of acute compartment syndrome, even in the presence of a peripheral block. And I've actually personally witnessed that a couple of times. So within the anesthesiology community, if our orthopedic colleagues have a concern about compartment syndrome, we usually use a lower concentration local anesthetic as to not mask the severe pain that usually comes about from acute compartment syndrome. For outpatient providers, PCPs in the community, when do you need to seek help or a consultation regarding possible complications or issues with block? After about 24 to 36 hours, if your patient has new onset paresthesias within the distribution of that block, pain, allodynia, hyperalgesia, any kind of paresthesias, it's probably time to chat with the anesthesiologist that placed the block, or even potentially a neurologist, just to evaluate if it's truly secondary to the block. If they continue to have numbness or motor block greater than 36 hours, it's pretty rare that a single shot block will last more than about 30 hours. It's not unheard of, but it's pretty rare. That's also a time to probably seek consultation from an anesthesiologist. If there's any kind of redness or swelling at the injection site, or any kind of concerns, fevers, things like that, concerns for infection, it's probably a good time to consult an anesthesia colleague regarding that.
All right, so huge part of what we do as anesthesiologists, and even working with surgeons, is multimodal analgesia. And this really started even 10 years ago in the heyday of opioids, but just trying to decrease it. So what does that mean? What that means is that you use different types of pain medicines so that you can overall reduce side effects but increase benefit. So some examples of that would be to schedule acetaminophen, schedule ibuprofen, and then if they need some oxycodone, to take that on top of it. With certain types of surgeries, maybe a spine surgery, you'd also want to, add some Lyrica or gabapentin. If there's a really big surgery too, or if they have some chronic pain issues as well, you might want to supplement with some ketamine or methadone. But it really just means try to use a moderate dose of a lot of different things to decrease overall. So, some
some just general basic principles, things that at least I recommend if people ask me my opinion on this. If it was my child having surgery, I would do scheduled non-opioid analgesics, acetaminophen and NSAID if it's okay with the surgeon, for the first 24 to 40 hours, regardless of how the child's feeling. Staying on top of the pain, not allowing them to fall behind for the first couple of days after surgery, which is typically the worst time period for post-operative pain. I think falling behind on pain, you usually have to spend a lot more effort to catch back up. Utilizing short-acting opioids such as oxycodone just for the breakthrough pain. Majority of outpatient procedures, a patient will need less than 3 days worth of opioids available to them. Many minor outpatient procedures, these kids need no opioids at all. Do not underestimate the value of non-pharmacologic analgesic strategies, things like ice packs, warming pads, aromatherapy, distraction with games and movies. Do not underestimate the value of these adjuncts to helping your child through the helping your patient through the first few days after surgery. They do work. There's a lot of evidence to support their use in decreasing opioid consumption. And also another important principle, avoid painful or anxiety-provoking routes of administration. IM, rectal, that will cause the child to underreport their pain. and also cause them to be fearful of any future medical interventions and even become fearful of non-painful medication administration routes. We're going to talk about some dosing and indications for certain post-operative analgesics. Just a quick disclaimer, we made every effort to make sure the dosing is correct on this, but it's always up to the individual physician or provider to double check and make sure that dosing is appropriate for their patient and for that patient's specific clinical situation. We will discuss off-label uses of medications that are commonly used in pediatrics. So first off, kind of the workhorse post-operative pain control and pain control in general, acetaminophen for kids comes in a liquid form, which is fantastic, 10 to 15 milligrams per kilo every 4 to 6 hours. Do not go over 75 milligrams per kilo per day or 4 grams per day. Max single dose 1,000 milligrams. Rectal is an option. Usually you can do a loading dose of 40 milligrams per kilo, and then subsequent doses can be 10 to 20 every 4 to 6 hours. The main issues with rectal is that the bioavailability of rectal acetaminophen is, even in the same patient, in between different doses, depending on bowel habits and bowel function and things like that. It's very variable. Acetaminophen is absorbed in the small intestines, not absorbed in the stomach at all. So the small intestines is the main location of absorption. And so really rectal is sort of, if you absolutely can't give the patient anything by mouth, rectal is sort of an okay backup, but it should never be the primary route of administration. Oral should always be the primary route of administration, if at all possible. Moving on into non-steroidals, there's a whole variety of non-steroidals to choose from. Most common, cheapest over the counter, ibuprofen, 5 to 10 milligrams per kilo every 6 to 8 hours. Celecoxib, so a selective COX-2 inhibitor. At least within pediatrics, it's utilized mainly for juvenile idiopathic arthritis. There's actually not great data to support its use in acute pain post-operatively for surgery. It only, in the United States, only comes in a capsule. So if the kid's between 10 and 25 kilos, they get 50 milligrams BID. If they're greater than 25 kilos, they get 100 milligrams BID. Much less platelet inhibition than the other NSAIDs on the list, albeit ibuprofen. If you look at graphs and charts of relative platelet inhibition, even ibuprofen, naproxen, their platelet inhibitory properties are pretty low, to the point where it's almost, unless you're really loading them with max doses over a long period of time, it's really, most people consider clinically insignificant. Ketorolac, there's actually very limited pediatric data, only comes as a tablet for outpatient. Really, for greater than 2 years and less than 16 years of age, really the only source out there was 1 milligram per kilo, max 10 milligrams, reported as a single dose after ear tube placement. Greater than 16 years of age, if they're less than 50 kilos, they get 10 milligrams every 4 to 6 hours, max 40 milligrams per day. If they're greater than 50 kilos, 20 milligrams. Naproxen, you can see some of the dosing guidelines there, and diclofenac. There's really no good evidence to support the superiority of one NSAID over another for post-operative pain control. I think it's really the go-to for us usually is ibuprofen on an outpatient basis. It's cheap, it's easy to get. You don't need to prescribe it to the patient. But there are other options out there. We're going to talk about another, it's an opioid, but it's also sort of considered a multimodal analgesic, tramadol. It's a dual action opioid. There's also one called tapentadol, which works in a similar way. They are mu-opioid receptor agonists, very weak agonists actually, but they also have effects at norepinephrine and serotonin reuptake inhibition. They are metabolized within the cytochrome P450 pathway. Tramadol has an active metabolite, the M1 metabolite, which is also a mu-opioid receptor agonist. Certain percentage of the population has decreased function, so decreased availability of that active metabolite, and so it will not work as well, if at all, in that percentage of the population. United States, liquid is not available. In Europe and South America it is, but in the United States we have various tab forms, instant release, extended release, this biphasic tabs that have both instant and extended release. The main issue in pediatrics and tramadol, kind of related to the metabolism of this. There is a US black box warning that came. There was a warning, I believe, in 2013, which then progressed to a black box warning in 2017. Really recommending it should not be used in children less than 12 years of age at all, and then should not be used in kids undergoing tonsillectomy or adenoidectomy. And in addition, between the ages of 12 and 18, if that child is obese, has obstructive sleep apnea, has lung disease, has any kind of underlying clinical issues that impair oxygenation or ventilation, really should not be used in those kids. And then some of the issues are, there have been case reports, kind of similar to codeine, of kids taking a single dose of tramadol and then having severe life-threatening respiratory depression. Luckily, the child in this particular case report got to an emergency room, was supported with positive pressure ventilation, and then was given some naloxone, and he was fine. Unfortunately, there have been reports of other children, toddlers, unfortunately passing away after single doses of tramadol and codeine, especially after tonsillectomy procedures. And
all right, so big part of this, why there's so many black box warnings, especially with codeine, which is something that I really want to bring home to anybody that I talk to not use it, because you really don't know what you're getting. So when you take codeine, a certain percentage of the population actually doesn't even metabolize it, so they're essentially getting placebo. And there's a certain percentage of the population that metabolizes it too much, and really that's the issue that we're running into. That's what's going to go and kill these patients, and that's why there is a black box warning. And it's a lot genetics too. So 1% of Swedish, but up to 30% in Ethiopian. So yeah, huge amounts.
So we'll touch upon a few other multimodal agents that are sometimes used in adults and kids. Dextromethorphan, it's actually, the adult literature is fantastic for acute and chronic pain. It's an NMDA receptor antagonist, and it's also a non-selective SSRI, sigma-1 receptor agonist, most commonly used as a cough suppressant over the counter, but it's actually, in the adult literature at least, a pretty good multimodal agent for decreasing opiate consumption. Unfortunately, in pediatrics, I looked around, I didn't see a single paper on it, so I can't really make a recommendation on that. Lidocaine patches, generally low risk in kids over the age of 12, and generally work pretty well. You apply, it comes over the counter, a 4% patch. Apply one patch to the painful area, make sure your surgeon's okay with you applying that patch to the area where the surgery was at, where the incision is. 12 hours on, 12 hours off, never use more than one patch at a time in a kid. Gabapentin, the pediatric data is mostly limited to posterior spinal fusion and prevention of phantom limb pain after amputation. The data for that's actually fantastic. There is a liquid oral formulation available. Typically we'll load these kids preoperatively with 10 milligrams per kilo, and then usually it's 5 milligrams per kilo 3 times a day for up to 5 to 7 days. Biggest side effect is sedation, which usually after the first initial initiation of therapy, that side effect actually usually decreases quite a bit after a few days. Pregabalin, for pediatrics, it's limited reports in pediatrics, mostly used for migraine, CRPS, seizures. I didn't really see any reports for use as adjunct for acute pain, albeit I do personally know a lot of people that do use it and are actually pretty happy with it as an acute pain adjunct, in a similar fashion to gabapentin. Others, anticonvulsants, SSRIs, TCAs, these are all different agents that absolutely have roles within the pediatric chronic pain world. In terms of the routine acute pain patient post-operatively, probably not as much of a role. I say routine because we as pediatric acute and chronic pain specialists and anesthesiologists will occasionally utilize these agents for acute pain for kids that are admitted in the hospital. But for your typical run-of-the-mill TNA that's going home the same day, we're not going to give them a TCA or an anticonvulsant. That's just would not be standard practice.
So 2 other quick things on the previous slide. The first thing with dextromethorphan, the most common thing that you might hear about some kids doing is apparently they like to drink the whole bottle, and it's called robo-tripping, so you may run into that. Second thing, gabapentin. As you get towards the younger ages, be a little bit more cautious about that, because there may be a little bit more mood side effects, specifically like suicidal ideation, sometimes hearing things, a little bit of psychosis. It's rare, but if it does happen, it tends to happen a little bit earlier. In terms of opioids, I'm giving you the regular opioids, and I'll talk about why we don't use combinations later. So oxycodone, that's probably the most common one that everybody's going to use. I'm going to do it for more the less than 50 kilos, because that's the weight-based dosing that you get. So it's about 0.25 to 0.5 milligrams per kilo per dose, and then that's about every 4 to 6 hours is needed. Hydromorphone, sometimes people do a lot better with that. A lot of times it just runs in families, or it's hard to really tell about who's going to do better, but if you do need to use it. Oral, 0.03 to 0.08 mg per kg per dose. IV, it's 0.015 mg per kg per dose every 3 to 6 hours. Of course, you can use that for a PCA too. Dosing's going to be different. Morphine, also can use that orally, 0.2 to 0.5, and in IV, it's about 0.05 mg per kg per dose. It's about 5 times more potent for hydromorphone than for morphine. We really try to do our best to avoid combination medications, and a big reason why is because we're doing so much multimodal. That's kind of the big reason. You're going to go and get some ibuprofen scheduled, you're getting Tylenol scheduled, but you will, if you're taking the Tylenol, oxycodone, or Percocets, for example, on top of that, then there's a possibility that you can take a lot more than you need to. There was a study that came out in 2012. I put that link down. You can reference that a little bit later, or not the link, the article title. But it basically says that if you are taking combination medications, you're more likely to overdose over time. So situations to avoid in pediatrics, a big one is codeine. It's got the black box warning in 2013. Tramadol, we talked about that a little bit. We'll want to avoid combination medications. And then a huge thing about any kind of opioid, specifically with tonsils adenoids, but really any kid that's bigger, there's an irreversible condition called death, which you may encounter. So one quick thing about codeine, we talked about this, rare ultrametabolizers up to 10%, so try to use alternatives. And then I took out a little part of this slide, but we also don't even recommend this using for cough syrup, as cough syrup, just because it's basically giving morphine to go and treat a cough, and nobody really wants to go and do that. So acute pain, chronic pain, any kind of pain, the best way to go and treat it is a biopsychosocial model. And you'll see this sometimes with some of your own patients. If you have a super anxious 16-year-old girl that's going in for an appendectomy, for example, her pain may not be as well controlled because she's really focusing on that pain and having a lot of issues dealing with that. So with some patients, it might even be good to work on some pain coping strategies even before the surgery, especially if you have some lead time. You obviously don't have that option with some of the traumas, but if you do have the opportunity to work on that, that would be great. And of course, getting people up and moving makes them feel better too, so physical therapy is huge as well. So what kind of pain coping strategies can we do? Well, we can use almost anything. You can use mindfulness, just trying to focus in on the minute, on the good. Sometimes people use some hypnosis. One nice thing about mindfulness is that it incorporates a bit of yoga as well. Distraction is huge. You can use some CBT or other types of psychological techniques, especially in utilizing a psychologist for those higher risk patients that you think might have issues after surgery. Biofeedback, that's another option that people do use. One thing that I don't really like about that is that you have to be connected to some kind of monitor to go and see how your heart rate, how your breathing changes the ball. So it kind of gives you a little bit of a crutch. And it's always good to work and practice these skills before you actually have your surgery. Yeah, I threw another study on there that really showed that there's decreased disability at 3 and 6 months. And at some point, we're hopefully going to be able to get a multidisciplinary, be able to do like a pre-surgery pain clinic visit for some of these kids that are going to be having some big surgeries that we think should use some of these coping strategies. We have a lot of references. The text here is super small, it's a 4, but if you go to reference it and then you increase it quite a bit, you should be able to zoom in to maybe see it. And then Hal, this is the questions, comments, discussions section.
Awesome, thank you so much. I'm just gonna stop sharing, and then while we can just stay here, because I think that's the camera.
Perfect.
Catch us all. I've got the whole session on my phone, so I can make sure we're actually in frame here. So thank you so much for a great overview of where we stand with opioids now, and some of these sort of multimodal things. I know I have a few questions. If folks have questions and you want to just put them in the chat, I can follow along with that, or feel free to unmute yourself and interrupt us anytime. One thing I feel like I'm trying to see more of, and this obviously applies more to sort of the inpatient realm, but IV Tylenol. Mm-hmm. When can we use that? Is it truly $50,000 a dose or whatever it is that they used to tell us that like it needs an attending signature every 24 hours, but I heard maybe it's not actually so wildly expensive.
Yeah, no, that's true. And it's a great question. So for the longest time, IV acetaminophen was not even utilized because we didn't even have it here. So I think probably around 5 or 6 years ago, it finally came into the market. And actually initially it was super reasonably priced. I think it was like $30 a bottle. Everybody loved using it. Great patient satisfaction. And then it got bought by another company, and then that's why the prices went up. It's still not super hugely expensive, but it's more expensive than the pennies per the pill. I strongly believe that you should never give rectal Tylenol, and that for any patient that is NPO, you should offer IV acetaminophen and schedule that as well.
I think the relative cost difference is significant. I think each bottle, if I remember correctly, is a little over $100 for 1,000. Basically, it only comes in one dosing. It's basically 1,000 milligrams, and if you want to aliquot that out, you have to have the pharmacy do it sterilely under a hood, which increases the cost of it. But each bottle individually, I believe, is a little over $100 relative to a $6.50 tab, which costs the hospital 5 cents. So I think the relative cost is huge, but the absolute cost of it's really not that bad. And I kind of agree with Tim, where the situations where we have an inpatient where, let's say they have an NG tube in, strict NPO, big incision, we're trying to basically get the bowels moving again. I don't use rectal. I write for 24 or 48 hours of IV Tylenol. Just because the evidence is so strong that if you minimize the opioids, control their pain, get them up, moving around, they have faster return of bowel function. They get out of the hospital faster, they do better. And so I think that the relative cost difference, I think it's worth it for the patient. And even though I haven't seen a study to support this, based on what I've seen, at least in terms of how they do and they get out of the hospital faster, I think the overall cost of their hospital stay might be decreased if you're employing things like that to help get bowels moving, get them moving faster.
Certainly. I mean, day in the hospital is a lot more than a bottle of Tylenol, or even 6 hours in the hospital.
Yeah, right. And as with every single day that somebody's here longer in the hospital doesn't necessarily get paid more. A lot of times they're now grouping these based on whatever charge they came in for. Like you get X amount for your appendectomy.
Right. Yeah, it's sort of a capitated world. But the other thing I thought was super fascinating was this idea of multimodal therapies and things that we can be doing. And it sounds kind of hippie, but you know, like clearly in my own experience, it's wildly effective to just try to get kids in a different mind space around discomfort. And you know, for people who aren't in a big academic center, and even here, like how do we promote that, get kids plugged into those ideas, do it before elective operations to the degree we can? Like, what are the services that are out there? Like, where do you look in the phone book to like figure out how to get these kids plugged into something like that?
So especially when you're talking about pain coping strategies, the best thing to do, especially in the community, is just to see what resources you have. Sometimes it may be a social worker that does therapy, but even any kind of breathing relaxation techniques that you can go and practice that before surgery, that is a big thing.
Yeah, like even like YouTube or whatever. I mean, like
YouTube.
Yeah,
There's
what are the
some
like
TED
resources?
Talks.
Yeah,
YouTube definitely has some good resources as well.
yeah,
I think if you're out in the community, let's say, and you're a surgeon or a primary care provider, and you're interested in integrating some of these, you may not have access to a pediatric psychologist that has specific training in pediatric acute and chronic pain. Even big centers don't necessarily have access to that service. I think if you're interested in trying to incorporate some of that in your practice, I don't think it would hurt to reach out to some of the larger centers that do have these kind of resources and just saying, hey, like, what are some references? What are some resources I could utilize to incorporate very simple tactics, very simple techniques that you don't need to be a psychologist to implement, that could potentially institute great gains for my patients in terms of decreasing opiate consumption, increasing their satisfaction with their perioperative care. If I was out in the community doing, that's kind of like that'd be my first go-to. And there are definitely conferences nationally around the United States. There's a big one in Minneapolis every year that are dedicated to acute and chronic pediatric pain. I know that there's, general private practice anesthesiologists that take care of kids maybe 25% of the time, that go to these conferences and try to learn some of these basic techniques. So
there's also a couple of apps that you can download. One of them, I forget if it's called Headspace or Mindspace. I think it's called Mindspace, but you can go and download that, and that gives you like 10 different things that you can work on, and then kind of gets you in a good mood and focuses just on yourself. So
cool. And we can link those on the
Yeah.
website for the enduring talk, so
Perfect.
that we can create that resource. But when would you say like kids should get seen by a specialist, particularly around this area of chronic pain? I guess like acute pain, there's less you can do, but I mean, you run the chronic pain
Right.
service. When should kids be coming to you?
I think that the biggest reason why people should come to us is number one, if you're trying a variety of different things and you're really struggling, or B, if you feel like you don't have enough resources. There's a lot of people that can manage chronic pain, and some kids that have chronic pain are managed by PCPs and do very well with that. But once you start getting out of your realm of comfort, for example, if you're starting to use more than one medication, or if you really want to try to go and get a definite psychologist, then you'll let us know. Because the way that we do it is that we have myself, a psychologist that takes part in every single new patient visit, and in every single follow-up is there as well. We have clinic once a week, and it's very small initially, just because we are waiting to get our full-time pain psychologist, who starts in October, and at that point it should be a lot better. And we triage every single person, so if somebody really, really severe needs to come in, then we'll work on trying to get them in sooner.
Fantastic. Awesome resources. Well, thank you guys so much. I think this has been hugely informative. I know I learned a lot. I'm going to go back and review some of those dosing guidelines, because I know that like always comes up, and even as we're sort of working to onboard more places that take care of children and trying to help, answer phone calls in the middle of the night, having a place to point them and say, like, this is how to think about this problem. I think this is hugely, hugely helpful. So thank you. If any questions out there from the audience, or issues that you're facing as you manage children in your practices. All right, awesome. Well, I'm going to just go run through a couple little concluding housekeeping issues, including the code for participating in our live session. So if you liked our session today, come back next month. We're going to be talking about emergency department use of opioids in June. Patients with chronic opioid use disorder. That'll be, so emergency department providers, chronic opioid use disorder is with Randy Brown, who is one of our family practitioner physicians who does a lot of work with patients with chronic opioid use and outreach around the state. In July, it's trauma and acute care surgery with one of our trauma and acute care surgeons. We're going to be talking about pre-hospital applications and the effect of prescription opioids in the pre-hospital experience. And then in September, we're going to be talking about primary care. So lots more coming up. We also do the Surgical Collaborative of Wisconsin, as I talked about, has this opioid initiative. You can learn more about that at scwisconsin.org. And we run a series of sessions sort of like this called Project Echoes. Randy Brown runs one in opioids. You can find out more about that at that website, femmed.wisca.edu/echo. And then we do sessions in pediatric emergency care, which is designed for pre-hospital and emergency department personnel. And then also a session called Surgical Indications and Continuity in Kids, which is for physicians who take care of children in the primary care setting. And I also have a podcast. So always pitch the podcast, surgery.wisc.edu/podcast. It's the surgery set. We talk about all sorts of different issues in surgery. Comes out every couple weeks. With that, the most important thing, this is how to claim credit for participating in this session live. So you will text TATKUH to 608-260-7097. That number will always be the same. The code will change every month. And if you are joining us live and subsequently want to come back and review the session as a video or don't get around to it, you can always go back and join these sessions that will be recorded online, and you'll be able to take a short quiz and get credit that way. As we said, opioid credit this time around is going to have to be managed in a retroactive way, but if you sign up for credit for just general CME, with that code, we will get you your opioid credit retroactively.